If you've been thinking about making the move to primary care, you're not alone. Every year, more and more clinicians make the move into primary care, but there are some hurdles that you must cover. My name is Camille, and I'm one of the founders of Pareto Education, and welcome to our YouTube channel. In this video, I'll explore the pitfalls that you can fall into when moving or transitioning to primary care. From December 2023 to December 2024, the number of full-time nurse practitioners in general practice nearly rose by 10%. The number with nursing associates is up by 55%. This demonstrates a clear shift happening, and a big part of that reason is the ARRS scheme, the Additional Roles Reimbursement Scheme. This is a pot of funding which has opened up roles for physician associates, pharmacists, paramedics, and first contact physios. Demand in primary care has exploded for these roles. Practices were hiring, and the career paths available in general practice are broader than ever. But let's pause here, because this isn't a sales pitch. Yes, there are opportunities, and yes, there's flexibility. There are some stereotypes about general practice, and you've probably heard a few already. Primary care is easier, it's just coughs and colds, and it's 9 to 5 with nice holidays. But let's be honest. Yes, primary care does have better annual leave policies, and you may find some flexibility with job planning or working from home, but the day job is anything but easy. In fact, it's a different kind of hard. You are often the first port of call for everything, from chest pain to psychiatric breakdowns to safeguarding concerns and newborn feeding issues. It's all coming through your door. And you'll often be the last person to leave. You're the one holding the thread between hospital, home, school, social care, and mental health teams. One of the big responsibilities in primary care is the admin, risk, and ultimate responsibility. Unlike in hospital medicine, where referrals and investigations happen fast and within a team, in primary care, the buck stops with you. You are the clinician making the referral, you're the one doing the safety netting, and you're the one who sees the patient again, or maybe never again. There are no on-the-spot chest x-rays for pneumothorax, there's no blood tests for chest infections, and sometimes there's very little available at all. And that means general practice demands a huge amount of risk management. It's not about deciding and ticking boxes. It's about thinking, can I safely watch and wait? Will this patient follow my advice? And what's my plan if they don't? Here's a typical example. You've got a 27-year-old woman who calls in with chest pain. The ECG is normal, but you suspect anxiety. But could it be a PE? Do you refer her in? What's your safety net? Do you call her in? What's the risk? And you'll ask this question multiple times throughout your day. Even referrals are tricky. The clinician on the other side can't see what you've documented. You can't have access to bloods. They've done primary care, so everything depends on you. It requires a change in mindset. Moving from secondary to primary care requires a shift in your mindset. In hospital, you're diagnosing acute disease, pneumonia, heart failure, acute kidney injury. In primary care, it's often about chronic disease management, optimizing hypertension, tweaking antidepressants, and monitoring HbA1c trends and interpreting blood tests. Imagine a patient presented with a raised ALT on routine bloods, no symptoms, no alcohol. What now? A viral screen? A fibroscan? Do you monitor it, or do you act now? Primary care is also holistic. You're not just managing diabetes, you're coordinating with the community dietitian, following up with safeguarding, talking to the school nurse, or filling out occupational health forms for work adjustments. It's a different type of work. The patient cohort in general practice can also be complex and challenging. Yes, you'll see challenging patients, but in general practice, you're the front line. The patient may have already Googled their symptoms, or they may have had a private consult with the letter in hand. They may already believe what they want. I want antibiotics, or I want diazepam, or the internet says I need an MRI. Antibiotics are a big one, and you may see a parent who wants antibiotics for a 3-year-old with a runny nose and a fever. When you clinically advise different, they become frustrated. So do you hold your ground, or do you give in and prescribe the antibiotics? This is where consultation skills meet boundary setting, and it's not always easy. You'll deal with angry patients, potential drug-seeking behavior, health anxieties, and sometimes inappropriate demands. These are all real encounters, and when you're face-to-face with that patient in a 15 to 20-minute swap, your name on the list is very, very tough. Independent practice and isolation. Another big difference in primary care is the independence. In secondary care, you often work in teams, and there's always someone on the ward you can ask a quick question to, whether it's the reg or the SHO. In general practice, it's quite different. Yes, you may have supervisors and clinical leads, but often you're working solo in a consultation room, and most of your interaction with your colleagues may be in the corridor or a quick chat over lunch. Getting advice is more formalized through case reviews, clinical meetings, or documented handovers. This means you'll have to get comfortable with independent decision making and taking full responsibility for your clinical adjustments. And before we finish, it's important to touch on the topic of pay. In general practice, pay is often negotiated locally or at the practice level, which can offer some flexibility, but it also means it can vary depending on where you work. This is quite different from hospital pay, which follows nationally agreed NHS pay scales. However, hospital pay is currently under review with Agenda for Change negotiations and aiming for updates which can improve conditions for hospital clinicians. The difference in how pay is structured can sometimes create challenges, especially around career progression. In primary care, because pay negotiations are often local, you may need to be more proactive in discussing your salary, responsibilities, and progression opportunities with your employer. It is also more likely to be affected by local or national budget cuts. It's not always as straightforward as hospital pay bands, so strong negotiation skills and awareness of local policies can be crucial. Understanding this aspect up front will help to manage your expectations and manage your career more effectively. And this is whether you're considering staying in primary care or moving back to secondary care in the future. So here are my final thoughts. Is primary care right for you? And should you make that jump? Well, if you value continuity, autonomy, and holistic care, primary care can be deeply fulfilling. If you like diagnostics, enjoy uncertainty, and want to be the clinician who knows their patient, it might just be your calling. But remember, always go in with your eyes open and realistic expectations. It's not easier, but it definitely is different, and it requires a new mindset, emotional resilience, and confidence in your clinical judgment. So if that excites you more than it scares you, then maybe primary care is the one for you. So that summarizes my video. So thank you very much for watching. Don't forget to like the video and subscribe for more real-world clinical training and reflections from the healthcare world.